not trying to squeeze in and figure out when we would do this. So I'm really grateful that everybody was willing to get on board and be here. For those of you guys who don't know me, my name is Heather Kirkendall, and I will be with you for nearly all of 420. I think everything except for 2 sim sessions. You guys get me. You get stuck with me. I taught 420 last semester. I absolutely love this course. My background is ER. We'll do a lot more of this tomorrow when we're in class because I want to meet all of you guys too. It is kind of a little bit strange to do the lab first and not have our full time together. Please do not hesitate to ask questions, raise your hand. This is a ton of content to get into this course. So my thought was we'll go through this today, and then any questions that we need to clarify as you guys study and get ready for on Thursday when we have lab again, we can go through it again then so that everybody's getting answers. So, but don't hesitate, raise your hand, ask questions. I'm happy to answer. On the screen, there's a QR code. If you guys will please complete that. That is just an attendance thing so that I know who's here, and yeah, I'll have it up here in a second again. Now, something you guys should know about me is I do start all of my classes with something positive, usually some sort of quote. So today's quote is "Follow your heart, but take your brain with you." So many of you guys have started nursing school and went, all right, here we go. And it may be a heart thing, but this is also a big brain thing too. So that's your feel-good quote of the day. Follow your heart, but take your brain with you. All right, here is that QR code again. You can also click on the attendance link. That's a live link on the screen. So heads up, there is an EKG test and a math test. Oh, hold on. Don't take control of my power. Taking it back. There's an EKG test and a math test. Both of those are going to be a week from today, Tuesday the 23rd. Excuse me, that's going to be from 8 to noon in Chem 106. Each of them does require you to score a 90% or better with one retest. The retest is Wednesday the 31st. Between 12 and 2 in Life Science 105. We will be reviewing math on Thursday in our lab. So don't worry, we'll revisit that and kind of the expectation for what some of those math questions will look like. I hope to give you all of the tools today to be able to successfully complete your EKG test without any problem. So, all right. Objectives for today. So we want to review cardiac anatomy, basic electrophysiology. You guys are not going to become electrophysiologists, I promise. The one on Blackboard does have a few less things in there. Like I don't put in the feel good one. I did add in the, I don't think I put in the testing dates either, but this is my version. And that's usually what I'll end up doing is posting a student version, and then I'll lecture off of my version because I need all my notes and stuff. I hope that helped, Jessica. Okay, then we'll go over normal EKG measurements, and then recognize and understand basic EKG arrhythmias and all of that fun stuff. So diving in, what exactly are we looking at? So part of what we have to have for today is reviewing the basic anatomy, the electrophysiology. Then these are the major rhythms that we're going to be reviewing. So what is normal sinus rhythm? Sinus arrhythmias, supraventricular arrhythmias, atrioventricular blocks or AV blocks, ventricular arrhythmias, and then asystole and PEA or pulseless electrical activity. Don't worry, we'll take some breaks too, because this is a long time to just sit here. Okay, so things to remember about the heart. One of the amazing things that the heart has the ability to do is something called automaticity. So this is the capability of the heart cells, the cardiac cells, to generate an action potential spontaneously without any external stimulation. So going back to patho, remember, and you guys will find out I love patho because I think that helps you guys understand what's happening in the body, what's happening with your patient. So going back to patho, that action potential is what is actually going to move the impulse through the heart and cause contraction. So it also has the ability for excitability. So cardiac excitability has this concept that cardiac cells undergo individual and sequential regenerative depolarization and repolarization. And this is how our cardiac cells talk to each other, how the top of the heart ends up allowing the bottom of the heart or saying, hey, ventricles, you need to contract, right? So we need that excitability. And then conductivity is that idea that those impulses are conducted from one cell to another. And it's that innate ability of the heart muscle to just move and transmit that electrical impulse to provide coordinated contractions. And then contractility. Hey, guess what? That's what actually pushes blood out through the rest of the body, right? So if the heart muscle did not have the ability to actually contract, what good would it be, right? It'd be awesome. Okay, we can do all this electrical stuff, but if it can't contract, it does us absolutely no good. So absolutely amazing what our heart can do. Now, the conduction system of the heart, we talk about it, everything originating from the SA node. Very top, the sinoatrial node. That's where the electrical impulse starts to move down the heart. And then we see it spread from the SA node to the left and right atrium, all the way down, bundle branch blocks. And I have this beautiful, all right, look at that beautiful conduction system in play. I think it also has, hold on. There's our SA node, our internodal pathways that help to get it through there. The AV node, the atrioventricular node, bundle of His, moving these all the way around, and then left and right bundle branches, and then to the Purkinje fibers. So it takes all of these pathways to really make the heart pump and do what it needs to do. Now, for those of you guys who this is a lot of information, let's break it down to something nice and simple with a very beautiful little heart here, right? So it's nice to be able to look at a heart in this manner Oh, look at all that. We got arrows here and arrows there and blue and red, right? Make it simple. SA node is the top of the right atrium, moves down to that AV node, which is kind of right there in the middle, between the right and left atrium. It actually is like right at that apex, right and left ventricle, right and left atrium, and we got all that information being passed down to those ventricles. Goes to the left and right bundle branches, which is down, whoops, sorry. Come on, go back. Sorry. Straight through here, and then out to the sides is our Purkinje fibers. So I like to try to make it a little bit easier for those of you guys who like the nice big visuals, and for those who need to just break it down nice and simple. So again, we have our beautiful conduction system here. Sazi, go ahead. If you're talking, you're on mute.
Sorry. I was just wanting to clarify, the one in the middle, is that the bundle of His, or is that the right?
Oh, you're cutting out really bad. What was that?
Is the part in the middle of the diagram you were showing a while ago, is that the bundle of His, or is that the right and left bundle branches?
Did anybody else understand what she said? Because it's cutting out for me. I'm sorry.
I'll just type it. I'll type it.
Okay, yeah, go ahead and type it.
You could keep going, it's okay. I'll just type it.
Does that help seeing that? Okay. All right, so things to remember is that wherever that impulse originates, kind of gives us an idea of, it clues us into how well the heart is working. So if we have an impulse that originates at the SA node, the intrinsic rate that the heart should be operating at is that 60 to 100 beats a minute. That's our normal range, right? I always put normal in quotes because we have these ideas of what normal is, but it's not necessarily normal, right? So normal range, 60 to 100, we can make the assumption that the original impulse is coming from the SA node. When the original impulse for the heart beat comes from the AV node, we're going to be at an intrinsic rate between 40 and 60 beats per minute. Same with the bundle of His, between 40 and 60 beats per minute. Anything that's in that region, this region right here, is the idea that it is a junctional rhythm, because it's kind of at that junction of where things are happening. So we expect it to be on the lower end of normal. Anything that's originating in the ventricles, whether it's the left and right bundle branches or Purkinje fibers, we're going down to 20 to 40 beats per minute. So if we think about, okay, the idea of how our heart pushes out that conduction is we're doing awesome if it starts where it's supposed to be, at the sinoatrial node up at the very top of the heart. But if it's having to go in a different direction, so if we're at that AV node, having to go back up and down. So it's at a lower rate. And then even lower when we're down at that intrinsic rate for left and right bundle branches, and then the Purkinje fibers. Those typically give us an idea that it's worsening heart blocks, which we'll go into. So. All right, so here we go with, what does this look like, right? How does this show up? How can we know what we're looking at when we look at an EKG? So this is our basic cardiac cycle in one little blurb here. I've taken it off of an EKG and just blurbed it right here. So the P wave, which is this very first little hump right here, the P wave represents atrial depolarization. So that's hope that we have SA firing, the SA node fires the impulse, and that atria is depolarizing. During that phase, the mechanical component of the heart responds to that electrical impulse, and both the left and right atria squeeze. They push that blood into the ventricles. Awesome, right? That's exactly what we needed to do. This section here, the QRS complex, represents ventricular depolarization. So that's where that AV node is firing and pushing it out to the ventricles. So sinoatrial node gives that impulse to the AV node, then the AV node says, okay, ventricles, now it's your turn. During this phase, the mechanical component of the heart is responding to that electrical impulse, and both the right and left ventricles contract. They squeeze blood either out to the lungs or out to the body, depending on, whether it's right or left ventricle. So the T wave up here is ventricular repolarization. So it's the AV node, the bundle of His, and the Purkinje fibers getting ready to fire again. So they're recharging. During this phase, we have both the right and left ventricles relaxed, and they are refilling with blood. So the most common question that we have during this time is, well, where's the atrial repolarization in the EKG? We generally cannot see that because it's buried in this QRS complex. The electrical stimulation is such that it overpowers any atrial repolarization that we would be able to see. So during the ventricle depolarization, that's where we would see atrial repolarization. Well, the ventricles are contracting and squeezing the blood, atria are relaxed and recharging and filling with blood. That makes sense. I hope this is all somewhat familiar from patho. Okay. All right. So when we are looking at segments or complexes, so segments, intervals, complexes, we start to talk about all these things, right? So an interval is the time that is one segment in one or more ways. So QT interval is this part from where the Q starts and the T finishes. A PR interval is where the P starts and the QRS complex starts. So we have those measurements, and they give us clues as to what could be happening with the body, or with the heart rather. So a segment is the duration of time between two waves. So here is that tiny little PR segment, an ST segment. We'll hear about ST elevation. That's a common cardiac condition that we see. This is what we're talking about. Normally it's on our baseline, which is our isometric line. But when this is elevated, it gives us an idea that there's some sort of cardiac damage, and we need to figure that out. What's happening and why? So if we're really breaking this down, the PR interval, so from here to here, that's the time that it takes from the SA node to travel, that electrical impulse to travel through the atria and get to the AV node. So if it's longer, it's taking longer for that electrical impulse to start at the SA node and move to the AV node. So there's got to be something wrong there, right? If it's not in that normal shorter period of time. For a QT interval, that is the beginning of ventricle depolarization through the plateau phase to ventricle repolarization. So it's giving us all of the ventricle activity. So what's happening in that ventricle? If it's wide and ugly, and wide and bizarre is one of our favorite ways to describe it, it's not repolarizing, it's not depolarizing and repolarizing the way that it should. So we want to really be looking at that. And then that ST segment I mentioned here, that represents the completion of the ventricle depolarization, where all that electrical activity goes back to that isoelectric line. And it just tells us, hey, everything's back to normal at this point. If we had trouble here, again, we're looking at what is happening in the heart, and each of these represent different places that could be going wrong with the heart. So one of the other awesome parts with the cardiac system is that has nervous control. So we look at parasympathetic and sympathetic nervous system. So for parasympathetic nervous system, the vagus nerve plays a huge role in cardiac response. So it decreases the firing of the SA node. It slows the impulse conduction of the AV node. So if you have somebody who is bearing down, like they're having a bowel movement, and they can actually change, because they're impacting that vagus nerve, they can actually change the firing of the SA node. So we'll see this when somebody maybe accidentally passes out on the toilet because they were bearing down too hard, but we also will use that knowledge and that understanding of impacting the vagus nerve to slow heart rates down. So if we have somebody whose heart rate is, 180, and say, okay, bear down like you're having a bowel movement, that can actually impact the vagus nerve, decrease that firing of the SA node, which we then see represented in that heart rate slowing. Now, the sympathetic nervous system has a ton to do with what we're working with as well. This guy increases our SA node firing, increases the impulse conduction of the AV node, and increases cardiac contractility. So how hard is that heart squeezing? Now, things that trigger our sympathetic nervous system. Epinephrine, right? We have that surge of anxiety when we almost sideswipe a car, or somebody almost sideswipes us, or we stop suddenly because we're about to have a car accident, and all of a sudden our heart rate is just, oh, okay. Thank you very much, sympathetic nervous system, right? This is helping us to say, okay, man, something's about to happen. Fight or flight comes into play. We have increased SA node firing, so that heart rate goes up. Increased impulse to conduction of AV nodes, so we're getting heart rate all around, not just our atria contracting faster, but also our ventricles. And now we have increased cardiac contractility, which is pushing blood out harder, meaning you now have the ability to fight or flight. All right? Does that make sense? All right, so looking back again at what exactly EKG monitoring looks like, remember this is a graphic tracing of electrical impulses. This is giving us a visual representation of what the heart is doing electrically. It's saying, hey, this waveform says that we actually have sinoatrial impulse going out. Look, we have our QRS, which means that we're getting depolarization of our ventricles. T, we have our repolarization of our ventricles. So we're really looking at that idea of what does each of these do and how does it represent, and why does it matter? Why does it matter that we know these things?
Because
this is going to help us. Go ahead. Sorry.
Because if your patient's having cardiac issues and you're able to identify the waveforms, then you can pinpoint what kind of issue they're having.
Absolutely. And it gives us an idea, like, is this a wow, that's an interesting EKG there. But it's not bad. It's just different versus, ooh, this is really bad and we need to get on this and fix this right away. So it gives us a big clue as to what's happening with our patient. It also gives us an idea of how quickly our patient may decompensate. Are they doing okay right now, but in 5 minutes, they're going to look like absolute garbage? These are things we need to know as nurses. So, EKG measurements. Isn't this fun? And I tried to find a couple different ones to give you guys, we'll go over EKG voltage and whatnot here in a little bit, but some of this really has to do with, because you guys are not, hold on, let me back up. We teach you EKG stuff to care for patients in any setting. That's the whole idea of nursing school, is we give you this baseline information. This is what you need to know to be able to pass the NCLEX and to competently care for patients of any variety. If you guys choose to go on to work in the ER, work in ICU, work in on a cardiac floor, you will get a lot more in-depth training on EKGs and all of that. When we're looking at EKGs right now, it is this normal or is this abnormal? Is this a baseline or is it good or is it bad? So when we're looking at these times, these PR intervals, QRS durations, QT intervals, it's really, is it within normal limits? I think somebody emailed me and said that one book said that PR interval is 0.1, and I have on here 0.12. 0.12 is what I learned as well, and I apologize, I did not have a chance to look it up in your textbook to see what the textbook says. 0.12 is what we'll be going on. How long is that PR interval? 0.12 to 0.2 rather. If it is longer, then we start looking at other conditions. Same with our QT interval. Is it narrow or wide and bizarre? And that's really what we're looking at. This is not a matter of you guys sitting down and measuring out the PR intervals, the QT intervals as we go through, because that takes calipers and all sorts of things. That's not the expectation for when you guys are taking the test. Anything that's going to be extended, if we have a longer PR interval or a wide and bizarre QT interval, you will be able to tell that. It's not, you're not having to show up to your EKG test with calipers to measure how far it is. So, okay. So 5-lead placement, everybody, does everybody know if you're putting somebody, is it Shayna? Is that how you say it?
Shay. Everybody calls me Shay. I just wasn't sure for attendance purposes.
Okay.
So I'm sorry, to go back to the PRI and the QT measurements, does that mean that there's not going to be any like first degree on the exam?
There will be, but it will be big enough that you'll be able to tell. And when we get to those, I'll show you. You'll be able to tell. It's
Okay,
it's
and
not
I messaged you. I messaged you about the QRS complex because it's here on 10, but the American Heart Association says like the bundle is 0.12 and greater, which would make the QRS duration 11.
So, like I said, we are not, what we're looking at is it a narrow QRS or is it wide and bizarre? And when we get to those slides with those rhythms on it, you'll be able to tell the difference. And wide and bizarre is very obvious. This is not, we're not sitting here and measuring, okay, we're at, and we don't do bundle branches in this one. We do not go over bundle branches. Bundle branch
sorry.
block
Section.
because that's like a cardiac floor ICU ER type thing. You guys do not, you need to understand the concept of a bundle branch block, like because of electrical conduction, but it's not identifying a bundle branch block on an EKG. I won't even get into those. It's way too complicated for the purposes of this. You guys don't need to know that for the purposes of this. Okay, so 5-lead EKG placement. Does everybody know how to put that on? If they handed you a remote telebox and said, hey, go put this on your patient. So they come in 5 different colors. Thank goodness for color coordination. So I've always done sky over grass. So it's like white clouds over green grass. Excuse me, and smoke over fire. So this is black over red. And then generally it's brown or yellow, depending on the company that makes it. Brown right in the middle. So sky over grass and smoke over fire. Chocolate in my heart. Oh, I like that. I like that, Ben. Chocolate in my heart. Yeah. So if you are asked to do a 5-lead placement, there you go. 12-lead placement, a little bit more complicated. So this one is really, fortunately, they give you right and left arm, right and left leg. So you can either do it here or on the wrist. You do over the hip or down on the ankles, depending on availability and access to the patient. V1 is going to go right in that same spot where chocolate in my heart. And then V2 through 6 essentially go under. If you think about a woman's breast, they go right underneath a woman's breast and they just whoop, swoosh there. Makes it nice and easy. So V1 and 2 are positioned right at that 4th intercostal space. V3 lies halfway between V2 and V4, which is V4 and V5, 4, 5, and 6 are horizontal, but not necessarily along an intercostal space. Now, for a woman, if you're having to put it on a woman, you do need to get underneath the breast. It cannot go on breast tissue. So it's a matter of like using the back of your hand and lifting up the breast. And it is actually better if they do not have an underwire bra on. That should come off because the underwire can impact, because we're measuring electrical activity. And it's really all the different ways that we're looking at the heart electrically. So an underwire bra can potentially impact what you are seeing on a 12-lead. Excuse me. So here is a 12-lead EKG. And this is representing a variety of different ways that we're actually looking at the conduction of the heart. Yes, over the area where you listen for the apical pulse, exactly. So typically a normal segment here, this little blurb here, this is a 6-second strip. And you see it with the dashes. So this is to 3 seconds, this is another 3 seconds. So that's 6 seconds of what's happening for electrical conduction in the heart. For a 12-lead EKG, each section, so you see here where it says the AV, V1, V4, these are 2.5 seconds, but they are all at the same time. Just different ways that we're looking at the conduction of the heart. So the first column is our limb lead. So that's 1, 2, and 3. The second column is going to be our augmented limb lead. So AV, AVR, AVL, and AVF. And then the last 2 columns are our V1 to V6. So we look at the heart through different ways because we can see different electrical activity based on how that impulse is going through. So when we're looking at the continuity of leads 2, 3, and AVF, look at electrical activity from the vantage point of the inferior surface. So looking up from the bottom of the heart. Lateral leads are leads 1, AVL, V5, and V6, and they're looking, that's at the vantage point of the lateral wall of the left ventricle. This is information to know. I'm not testing on this. Septal leads look at the septal surface of the heart, that interventricular septum, to give us an idea what's happening there. And then anterior leads, V3 and V4, look at electrical activity from the vantage point of the anterior wall of the left and right ventricles. So just giving us an idea of what exactly does that patient look like from all different ways that we can look at the electrical activity. Now, for some patients, we may need to prep them because they may be too hairy to have EKG pads stick to them. So if you need to clip it or shave it, that is perfectly fine, but just shave the little sections that it's going to be. Rub the skin with dry gauze. You may have to use like an alcohol prep pad if the skin is especially oily, and then you just apply the pads. For a 5 lead, based on the way they're usually like a little snap button. Put the button, snap it onto the lead before you put it on the patient. Snap the pad. Because if you put the pad on and then you snap it on the patient, that actually really hurts. I don't know if anybody's ever had that done to you, but if they put that lead on and then they're trying to snap onto your chest, it does not feel great. So put those leads onto your, put the electrical pads onto your leads first and then put them on the patient. They'll be much happier with you. All right, now on to voltage. So we're looking again at what is happening on the EKG and how that's running for us. So one small square, so that's one of these teeny tiny squares right here. It's 1 millimeter and it's equal to 0.04 seconds, which then gives us 5 of those, which makes up a bigger one. One large square for 5 small squares equals 0.2 seconds. And then 5 large squares. So if we go 1, 2, 3, 4, 5, 5 large squares equals 1 second. Does that make sense? Okay. So when we are looking at measuring heart rate based on an EKG, there's a couple different ways that we can do it. The large square method is utilizing this whole idea that each square gives us so much time has passed, right? So when we look here, if there are, in this case, we have 1, 2, 3, 4, 5 in between each heartbeat. We calculate that by dividing 300 by the number of large squares between each R to R interval. So this is an R to R, top, R to R, R to R, R to R, R to R, okay? So if we only have one large square between our R's, we divide 300 by 1, that gives us an approximate heart rate of 300 beats per minute. Here we have 2 large squares, so 1, 2. We divide 300 by 2, that gives us an approximate rate of 150. and you can see as they get further apart, how that works out. So we have 3 here, 1, 2, 3 large squares, divide 300 by 3, approximately 100 beats a minute. 300 by 4, because we have 4 large squares. Now, to use the large square method, you do need to find a QRS, an R, that lands on a darker box so that you can measure out how many big boxes are between the next R. So it depends on what you have for being able to measure that out. Does that make sense for the large square method? Okay. Sort of? Okay. You don't have to use this. We can use the small square method, which gives us a whole different way to look at it. So here we're actually counting the small squares. So here we have 1, 2, 3, 4, 5 small squares. Here we have 10 small squares. Here we have 15. And in this case, you're dividing 1,500 by however many small squares you have. This is easier to do if you have where you're not getting an R complex that's falling on a dark, right into those big boxes. So, if it was like here and here, you can still count the number of small boxes between the R's and be able to get an accurate reading. So in this case, we have 5, divide 1,500 by 5. In this case, we have 10, divide 1,500 by 10. We have 150 beats. In this case, we have 15 small boxes, divide that by 1,500, approximately 100 beats per minute. Now, this is great for, like I said, for those ones that are not following on a big, dark, bold line. Now, yet another way to measure is our R waves. So how many R waves do we have in that 6-second strip? So going through and counting 1, 2, 3, 4, 5, 6, 7, 8, 9. So if we have 9 in 6 seconds, we're going to times that by 10 to get a full minute to get our beats per minute. And here they're showing the small squares, large square option, and then R to R. Any questions? In this case, they did a 10-second strip, but if it's a 6-second strip, you're doing it by 10. Okay. So to calculate the heart rate, you have different ways to do it. You can actually count the number of QRS complexes in 1 minute. If you have somebody who is super irregular and you can run a 1-minute strip, great. Count the number of QRS complexes in 1 minute. Or you count the number of R's in 6 seconds and multiply by 10. Or, and you can take a picture of this, and it depends on how you want to do it. Number of small squares between R to R, divide into 1,500, or number of large squares between 1 R to R and divide into 300. So it just depends on what you prefer to do. So questions, comments, concerns, anything for right now?
On the exam, is
The
it
R
gonna...
wave method, this one? So in this case, they have a 10-second strip, which is not what we normally do. So let me pull up. Here's a 6-second strip, okay? So here's our QRS complexes. So we're going to go 1, 2, 3, 4, 5, 6, 7. And then we're going to multiply that by 10 because it's a 6-second strip. So the heart rate on this one is approximately 70.
So is that an appropriate answer for the exam, or do you want it to be like 74?
No, that's an appropriate answer.
Okay, are the strips on the exam going to be 6 seconds?
Yes, they are
Okay.
6 seconds unless otherwise written out. But the assumption is, especially if you see hashtags here at the top, these are time marks. So there's 3 seconds and then 6, there's another 3 seconds. That a strip is a 6-second strip unless it's otherwise indicated. So, all right. Any questions? So let's take, I know this is a lot to take in. So let's take a 10-minute break and be back at 1 o'clock. Everybody can just stay on. I'm going to mute. So the PowerPoint that I'm teaching off of, most of it, except for like the break slides and stuff like that, are already posted in the lab section in 420, in the main 420 course. So you can look at that there as well. So let's be back at 1 o'clock and we will jump into actually looking at strips. So the only thing that's missing off of the one that I posted is like my extra stuff, my extra slides, like time for a break and that sort of thing. So that PowerPoint is already posted under the lab section of the main 420 course. Right. Did you have a question, Jessica?
I think I'm just getting confused because the one that I have is completely different. If that makes sense. Like that most of these slides are not on the one.
Let me look and see what is there. Hold on, let me get into Blackboard.
And it's just getting kind of hard to follow.
Well, because if you logged in, hold on, before, well, no, you wouldn't have had access to it. Let me just double check. Hold on. I'll double check on that and make sure. What did I post? Hold on. Lab information. So the one that's listed under the lab day is one from a different instructor.
That makes sense. That's what I was trying to get at when I first said that the PowerPoint was different. So I'll see if I can find the other one.
Yeah, the other one, if you just scroll, hold on, if you're on that same, on the same 420 lab, if you scroll to the bottom underneath like our days, it says basic arrhythmias PowerPoint, and then it says EKG class spring 2024. That's the one that I'm working off of. The other one is from a previous instructor, which I apologize, I did not realize was part of that.
Also, Harley's in the chat and said that she can send it to you if you need it.
Okay, thank you guys. I was very confused the whole time.
Yes, I don't blame you. Of course you were confused. No, you should be good now. And I actually just made that other one hidden because that's too confusing for people. Are the small square and large square methods over 6-second intervals? So you're only measuring between R to R. So it's one little section when you're doing the small square and large square. You may need to do it over a couple different places if your heart rate is irregular. So if you have one that has, I don't know, 8 small squares between it, and then the next section has 12 small squares between it, you know, you would want to double check, because if your heart rate is irregular. But it's not, you're not measuring each section in that 6 seconds. You're really only measuring between one R to R for small square and large square method.
Okay,
That makes sense?
I got it. Yeah, I might, if I still don't get it, I might look it up online, and then if I see after lecture tomorrow, I might ask if you could show me an example.
That, and we can talk about it on Thursday as well. I'm gonna do, we're doing stations, and the station that I actually have is crash cart and meds. So I plan on doing any EKG review then as well. So we can go over it then too again, to be able to understand it a little better.
Thank you.
You're welcome. To answer your question, Joy, we will be going over a lot of EKGs. And anything, those will be similar to what is on the exam. So do not worry about not seeing enough. There's plenty, I promise. I think of my PowerPoint, like 70 slides is actually content. The rest is all EKG slides that we practice. So you guys will get lots of practice. All right, so it's 1 o'clock. Let's get back to it. So how do we find out if what we're looking at, right? That's the whole point. So again, here's our 6-second strip. So there's 5 steps to make EKG and understanding rhythms easier. Yeah, we'll go with easier. So number 1, rhythm. Is it regular versus irregular? Is it coming up boom, boom, boom? Or are we doing boom, 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 boom? You know, it's just like all over the place, right? So we need to know, is it regular versus irregular? So first question when you're looking at a strip. Second question, and we're going to practice putting this 5-step approach every time, because I go through them each this way. So what we're talking about for regular versus irregular is the interval between the R waves regular, and it comes right as it's supposed to, or is it irregular? Second, what is the rate? So that's going back to what is our actual rate? How fast is the heart beating? So we can use counting our R's, or we can count large squares, or we can count small squares, however you want to determine. So in this case, counting the R's, we go 1, 2, 3, 4, 5, 6, 7, 8, 9. Multiply that by 10, and we have an estimated heart rate of 90 beats per minute. Okay? So PR interval is the next, or P waves rather, sorry. Now, when we're looking here, is there a P wave for every R? And is there a QRS for every P wave? That's what we want to know. Does it happen? Are we actually getting what we need? P waves, are they present? Is there a P wave for every QRS complex? Are they occurring regularly? Our PR interval is going to be our next question. Is it short, 0.12 to 2 seconds? That's 3 to 5 small boxes. Or is it longer? Okay. And then for our QRS, that's our next point. Is it narrow like it's supposed to be? Or is it wide and bizarre? So the normal intervention is between 1.5 to 3 boxes, so 0.06 to 0.12. That's what is it narrow? Is it wide and bizarre? And as we get into strips, you guys will look and say narrow, wide, and bizarre. I don't even need you guys to tell me what that number is in between. And then do they all look about the same? Do the QRS complexes all look about the same? If they're different, then we know that there's some sort of electrical impulse that's not the same as the others. It takes me back to Sesame Street. Which one is not like the others? That's what it reminds me of. How come? Why is it not like the others? And then the last thing that we're going to look at is, what is the clinical significance? So if we look at something and we're like, oh, wow, that is really strange. Now let's look at the patient. Are they presenting normally? Are they okay? What's our signs and symptoms? That's what we want to then base our clinical significance on. Now, for the PR interval, we want to make sure that it is normal. So it's between 0.12 to 0.2 rather, which is about 3 to 5 small boxes. So you just want to make sure, is it close to that QRS complex or is it further away? All right, so now we're going to start putting this into practice, and we will put this into practice for every single one that we do. So when we determine the rhythm, looking back, would you say this is regular or irregular? What do you guys think? It's absolutely irregular. Yeah. When we look at this one, regular versus irregular. Just a quick glance, right? This one here, this one's regular, irregular, right? So we want to be able to quick glance, regular versus irregular, okay? Second step, let's determine that rate. So we have our different ways that you want to do that. We can march out those R's, 1, 2, 3, 4, 5, 6, 7, 8. Multiply that by 10, because this is a 6-second strip, gives us a rate of approximately 80. Then we want to look for those P waves. First of all, are those P waves there? So here we have a P wave, a P wave, a P wave, a P wave. Okay. Oh, Amber, okay. So when we're looking at, so we measure heart rate in beats per minute, right? Everybody agrees with that? So if I say my heart rate is 105 right now because I'm nervous and I'm talking to you guys about cardiac stuff. Even if I don't say beats per minute, everybody knows that I mean that my heart's going 105 beats per minute. So with 6 seconds, that's only representing 6 seconds to make up a full minute. We multiply by 10. So then we can say what our beats per minute are. Does that make sense? Okay. All right, perfect. All right, so P waves. We got them here. We do not have P waves here, right? We have our isometric line. We have QRSs, but there is no obvious P wave like we have here. These are beautiful P waves. Look at those gorgeous P waves, all right? We also want to see, are the P waves occurring regularly? Do we have them marching out regularly, right? Are they in the same set of regular? Maybe we'd miss a P wave. Well, guess what? That means that they're not regular P waves, right? Which we'll talk about that too. So here's our PR interval. We want to see how long that is. Typically, it's that 0.12 to 0.2, 3 to 5 small boxes. So I don't have this on a grid, but this should be short. When we have this longer, we have other conditions, and we'll talk about those when we talk about AV blocks. Now, QRS complex. Normal QRS between 0.12. Whoops, sorry, wrong one. I'm skipping. I'm on the wrong thing for me. Normal QRS is between 0.06 and 0.12. About 1.5 to 3 small boxes. So remember, when we're measuring, that's actually measuring seconds. So that normal interval is 0.06 to 0.12 seconds. Okay, because this is our length of time as we go through. This is a length of time, remember? So each one of these is a length of time. So do we have them? Is it narrow or is it wide and bizarre? Do we have a QRS complex for every P in the strip? So here, QRS and P, QRS and P, QRS and P, right? So we want to make sure that it's all there. Now, the other thing is, do the QRS complexes look about the same across the EKG strip? Or are they totally different looking? Because that's going to give us an idea, is the electrical impulse following the same path every time? That's what the look gives us, it tells us. All right, and then lastly, clinical significance. What does our patient look like? Are they asymptomatic or symptomatic? Are they lightheaded, dizzy, pale, diaphoretic? If they have this EKG and I'm like, wow, you know, the rate's good, the rhythm's good, we have Ps, we have QRSs, it's 80, and they're super symptomatic and they look like garbage, that's really concerning to me, right? Something is going on. If I have this rhythm here, I've got their wider QRSs, my P waves are gone, but my patient is sitting there and they're there for a stub toe and have no cardiac complaints, I'm not going to be as concerned, right? I'm going to ask them follow-up questions, but I'm not going to be as concerned. That's why we want to be looking at that clinical significance. All right, now we have this fun little thing called artifact. So sometimes we may look at this top one and go, oh my goodness, the patient must be in some really bad rhythm. We see the QRSs. Don't panic. Make sure your leads are on right. Check the patient. Same thing here, this bottom one, that's a loose electrode because the electrical impulse can't get through to tell us what's actually happening. So before just automatically jumping and being scared of what's going on with the rhythm, check your patient, check your leads. There will not be a trick question on the exam like, what is this rhythm? There's nothing like that, okay? Now we do have telemetry monitoring where we are wanting to observe the heart rate and rhythm from a distance, depending on what's happening with our patient. So if you take care of a patient on a medical floor, med surg floor, but they do have an underlying cardiac issue, then they may be on tele that's being monitored by somebody, usually a teletech, and they'll call you and be like, hey, man, their rhythm's showing up really weird. Can you go check the leads, right? Or their heart rate was 80 and now it's 40. You need to go check on your patient, right? There's great advantages to that because it gives us an idea of what's actually happening with our patient. Generally, if you have a cardiac patient, they'll be printing off those strips depending on the policy of the facility, hourly, every 3 hours, every 4 hours, depending. But it can give us, do we have dysrhythmias that we would not have seen otherwise? Do we have potential ischemia that may not be showing up that we can catch before the patient starts to decompensate? So, and then we have it's not listed as, I mean, it's considered remote, but it's not really remote, but where we actually have the monitor in the room and then it remotes out to the nurses station. So we often see that ICU, ER, pre-op and PACU. We kind of see that kind of monitoring system there. Now, here we go. We're going to start digging into some rhythms, all right? So, and I tried to put, so we'll go off of one main one, and then I'll add another strip. So you guys can kind of see how they may look different, but they're still the same thing. So we're going to break this down the same way that I talked about. So is our rate regular versus irregular for this one?
Regular.
And then does somebody want to tell me what, well, that's cheating because I already have it up there. I forgot it. Well, we'll do it on the next one. So everybody can see how this rate is 70 beats per minute. 1, 2, 3, 4, 5, 6, 7. That's a 6-second strip because it's not indicated otherwise. So 6 times 10, 70. We have a P wave for every QRS, right? We have a QRS for every P. Yes. So if the EKG is regular, well, so no, it actually has more to do with, we assume based on the rate, it's between 60 and 100, that it's originating from the SA node. So that's sinoatrial node. So sinus is where we get that assumption, is that it's from, because the rate is within normal limits between 60 and 100. That's where that sinus comes in. It's indicating that the start of the impulse comes from the SA node. For some reason, those words were not coming out right. I apologize. Now, clinical significance. If we have a patient in normal sinus, everything's looking great. Our QRS is present for each P wave. It's narrow. There really isn't a clinical significance unless your patient has no pulse. If your patient has no pulse and this is showing up, we have something called PEA, pulseless electrical activity, in which we still have electricity going through, but no mechanical portion happening with the heart. And we'll talk about that some more later. We still want to look at our patient. What does our patient look like? Are they symptomatic? Are they asymptomatic? Do they have any cardiac complaints? Chest pain, shortness of breath, fatigue with exertion, anything like that. We want to know what's going on with our patient. So here is the next strip. So if somebody wants to tell me regular or irregular. Right, it's regular. And what's the rate on this strip down here? Okay, that's totally, I guess I didn't realize I put 2 70s up there. All right, so we have a rate of 70 again. We have a P wave. P, P, P. That one's kind of little, but it's there. P, P, P. And is our PR interval, is that okay? Yeah, right up there, right where it needs to be. Do we have a QRS for each P wave? Yep. PQRS, 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 right? So are we going to be worried about this patient if they're alert, oriented, talking to us? No. We're just going to be chilling with them. Awesome. Awesome. We're doing great today, right? Okay. Sinus Brady. So we still meet being healthy. Maybe, yes, and we'll actually talk about that here in just a second. So rhythm, regular or irregular? Regular, absolutely. Our rate is 30. So we have 1, 2, 3. We're assuming that's a 6-second strip. That's a rate of 30 beats per minute. We have a P wave. They're upright and regular. Our PR interval, right there within normal limits, right? We have a QRS for every P, and it's narrow. So our clinical significance for this patient is going to depend on how they present, okay? This could be an Olympic athlete or somebody who runs triathlons or marathons, or somebody in the military because they have PT and are working out all the time. Okay. This also could be somebody who is not perfusing their brain with a heart rate of 30 a minute. So it depends on what your patient looks like. Okay. Okay. Let's try another one. Oops. All right, let's try this one. How's this one? Regular or irregular? Potentially with hypothyroid, they usually don't have a heart rate that low. All right. Do we have P waves? Yeah, we have these tiny little P waves in there, right? We have QRSs that are narrow. We have a P for every QRS. We have a QRS for every P, right? Again, clinical significance. What does your patient look like? Oh, sorry. Okay, here's our next one. Regular or irregular? All right. We have P waves. Yeah, look at those sweet little P waves. They're within normal limits. Our QRS, we have present for every P, and it's narrow. I would not, it does not say what lead it is. But given that we have the QRS below the isoelectric line, I would say yes, it's not lead 2, which is typically what we see, is lead 2. But I don't know what lead that is because it doesn't say. Great question, Ben. Yes, so we still would, so these are marching out 1 second. One second. So we have 1, 2, 3, 4, 5, 6. So we're still looking at that 6 seconds. Here, these are marching out 3 seconds because they're bigger sections. So that's a 6-second strip. This one here doesn't give us a good vision of 6 seconds, but we're assuming it's 6 seconds. So, all right. So sinus brady, some of the things that we see with our patients who have sinus brady: hypotension, pale, cool, clammy skin. They can be weak. Potentially, this is where we would have somebody who can pass out. They could be dizzy. They may or may not report chest pain. Depends on why they have a low heart rate. Why do you think we have confusion or disorientation with a low heart rate? Poor perfusion, absolutely. Our poor little brains, man, our brains need that pumping, right? So low perfusion of oxygen to the brain. Exactly. So again, potentially why they're weak, because they're just not perfusing everywhere. Shortness of breath, especially with exertion. So if we think about our patient who has sinus brady, if they are not used to it, if they are not a physically fit, active person who just automatically has a low heart rate, if they are not used to having that slow heart rate, they likely will have signs and symptoms. So what do we do for it? First of all, if they're on any medications that are causing it, we stop the drugs. So if we have something and we're like, whoa, that really dropped their heart rate, right? We're gonna stop that medication. If necessary, we do IV atropine. They can get a pacemaker. And then depending on how stable or unstable they are, they may get dopamine or epinephrine infusions just to, let's bump up that, that heart rate and our cardiac output. Make sense? Okay. So I have a question here. You guys can fill it out if you would like. QR code, and then this is also a live link. So a patient's cardiac rhythm is sinus brady with a heart rate of 34 beats per minute. If the bradycardia is symptomatic, the nurse would expect the patient to exhibit palpitations, hypertension, warm, flushed skin, or shortness of breath. Which do we think? Yeah, absolutely. Looking back on our previous slide, we could also have a patient with pale, cool, clammy skin, hypotension, generalized weakness, dizziness, syncope, confusion. So they generally don't look great. All right, so now we're going the opposite direction. Sinus tach, sinus tachycardia. First off, are we regular versus irregular? Regular, yep, absolutely. And what is our rate? How fast are we going? Yeah, 140 for this one. Now, it's kind of hard to see these P waves right here. P wave, P wave. They're in there. But because of how fast we're going, we do have a P for every QRS, and it's upright and regular. PR interval is still within normal range. We have a QRS for every P, right? QRS for every P. And it's narrow still. And then clinical significance. Again, this is going to depend on our patient presentation. Typically, sinus tach does not require treatment. We may see it as a compensatory mechanism because of an underlying issue like a fever, anxiety, hypovolemia, or shock. And in that case, we need to treat the cause. Okay? We don't want to just drop their heart rate if they have bled out 2 liters and we drop their heart rate. We have really bad things happening, right? So we need to correct the underlying cause. Rates between 100 and 150. No, we're going to do SVT in just a second. Rates between 100 and 150 generally do not cause serious signs and symptoms and can be sustained. and think about things that will increase our metabolic rate, and why we would have an elevated heart rate. So fever increases our metabolic rate. If we're losing blood, our patient's going to be trying to compensate for that in some way. Or if they're volume depleted, maybe they haven't actually lost blood, but they're volume depleted because of nausea, vomiting, diarrhea, going to see an increase in heart rate because the body is trying to compensate for that. Fix the underlying cause, and we should slowly see that heart rate come back within normal limits. Sepsis, absolutely. All right. Rates over 150, anything over 100 is considered tachy. So 60 to 100 is normal sinus. Anything above 100 is tachy. Anything below 60 is Brady. All right. So here is another one to try. So there's one. So what is our rate on this? This is a 6-second strip, even though it doesn't tell us. What are we going to call this one? 120. Yep, absolutely. Regular versus irregular. Still pretty regular, right? Yeah. We have P waves in there. They're also a little bit difficult to see. And then we have a P for every Q and every QRS, and a QRS for every P. And our QRS is still narrow. Okay. All right, here's another one. What's our rate on this one? Approximately 130, right? Regular versus irregular. Regular, all right. Look at all those P waves. Oh, they're so beautiful, marching out like that. They're present, normal length. We have a P for every QRS, a QRS for every P. Our QRS is still narrow. And again, for our patient, our clinical significance, this is going to depend on what exactly our patient looks like. All right. Questions about sinus, Brady, normal sinus, sinus tach. We good with all those? So for patients who are symptomatic with sinus tach, you can have shortness of breath. They can be hypotensive. They can have chest pain, especially if they have a history of coronary artery disease. They can be dizzy. Why do you think we have the same or similar manifestations with sinus tach as we do with sinus Brady? We have opposite things going on. Yes, exactly. Still poor perfusion. So if our heart rate is going too fast, the ventricles cannot fill adequately to then pump adequately. All right, so we're still going to have them looking kind of crappy. They're still going to be potentially, depending on if this is close to their baseline or not, they're still going to look like somebody who has poor perfusion because they are not getting great perfusion. So treatment that we see with sinus tach are going to be guided by the cause. Again, what is that underlying cause that is causing that patient to present this way? Do they have a fever? Do they have low oxygen saturation? Do they have low fluid volume? What's happening there and how can we fix that? Vagal maneuvers, which I mentioned earlier, that's bearing down like you're having a bowel movement that impacts the vagus nerve, working on that sinoatrial node to slow down heart rate. They may also get beta blockers, adenosine, calcium channel blockers, depending on if the patient is stable versus unstable. I have a inappropriate sinus tach. They have no idea why. I just hang out in the 120s. Doesn't feel great. So I'm on a beta blocker all the time. Awesome. You know, great. So, you know, it really depends. If your patient is on a beta blocker, we don't automatically want to assume that it is for blood pressure. Ask them why they take it. And hopefully they'll be able to tell you why. Now, if they are unstable, then we would consider synchronized cardioversion. And I am actually going to skip this one because I'm not asking any questions on those. Okay, here is our SVT or PSVT, depending on. So paroxysmal means fit, attack, or sudden increase or recurrence of symptoms. So you'll often hear SVT referred to as PSVT because you'll see your patient go into it. And I have a strip. I actually have 2 strips that demonstrate that here in just a second. So with SVT, we will still see a regular rate, right? So our rhythm is pretty regular here still, right? What is our rate though? That is stinking fast, 190 beats per minute. You may or may not be able to see P waves. They're present, but they can be difficult to see, kind of buried in the T, which we have a couple in here, that are buried because of that rapid rate. A PR interval, if we can see a P, which we can kind of see one here, will still be within normal limits. The QRS is still narrow. Again, our clinical significance is going to depend on our patient presentation. Typically with SVT, it has an abrupt onset and can terminate just as quickly as it comes on. This can happen with patients with high levels of stress, overexertion, high levels of caffeine, which I don't know if you guys have heard about the lemonade situation that Panera has. Apparently it has stupid high levels of caffeine, and they were seeing patients with SVT based because of that. I think it's a lemonade, which just blows my mind. That's a ton of caffeine to be able to do that. There's other conditions called Wolff-Parkinson's White, WPW, meth, unfortunately, yes. So medications can do it, other things that patients may ingest. It is generally tolerated for a short amount of time. So runs of SVT oftentimes are felt like palpitations, and the patient may just be like, "Oh, that felt funny," and that's literally like less than a minute, 30 seconds or less, right? Those quick palpitations, you're like, kind of caught me off guard, right? Treatment is generally not needed if it stops on its own. If they have runs and then it stops, we're good. If the patient is unstable, rapid intervention is required to treat and correct SVT. And synchronized cardioversion is generally what is done. For symptomatic but stable, you can try vagal maneuvers initially, especially if you are like somebody's getting the crash cart to be able to get ready for cardioversion. There's no harm in trying vagal maneuvers. Go for it. Now, the patient who has this, so here's an example where we have the patient is in SVT, and then they go into normal sinus. All right. And that's where we'll go into that paroxysmal PSVT. And then same here, patient normal sinus, we have a run of SVT, and then they're going back into normal sinus here. So you can see how these would be much harder to determine a rate, right? So what you would want to do is do our boxes. So, you know, pick one and count your boxes between. So in this case right here, if we're going with, let's see, this one's on a line. Hold on, I have it on my bigger screen where I can see it a little bit better. But then we can count our boxes, which this one is probably about 300 a minute if we're going with small boxes. Going off of here. This one is not quite as fast. This one's about 150. But we call this PSVT because they were in a normal, or they were in a slower rate, escalate into that run of SVT, and then they go back. Does that make sense? Okay. So manifestations of SVT or PSVT, we generally see them 151 beats and above, 150 to 220. Heart rate greater than 180 though, we know that's going to lead, you can't hear me? Can everybody else hear me?
Yeah.
Okay. We know that our cardiac output is going to decrease the higher that rate goes, right? Our stroke volume is going to decrease. The higher that rate goes, the lower our cardiac output. So we're going to see those same kind of signs and symptoms with low perfusion, hypotension, palpitations, shortness of breath, potentially having chest pain, pale, cool, diaphoretic. They may just look like absolute garbage. That patient is unstable and needs rapid intervention. Okay. So initially we'll look at, let's try that vagal maneuver. It's worth a try. If we're gathering meds and we're gathering a crash cart, it's not going to hurt. Right? So we look at IV adenosine, IV beta blockers, calcium channel blockers, and then synchronized cardioversion. So some examples of beta blockers that we may use: carvedilol, propranolol, metoprolol. Calcium channel blockers that you may see: diltiazem or verapamil, amlodipine. If a patient has a history, they may be on it to help reduce that risk. All right, let's do another little break before we, oh, let me see what we're doing. Oh yeah, because then we're starting into atrial flutter. So be back at 5 till 2. We'll do 10 minutes and then be back. Any questions before we go? Yeah, I was gonna say, I thought I downloaded it already. Okay. All right, we'll be back in 10 minutes, guys. All right, you guys ready to head back to it? Amber, if you go under modules and then go to module 1, that's where you'll find the link. They're under each date. I don't have anything for week 2 unlocked yet, but week 1 is there. Oh, thanks for sharing that, Ben. Yeah, it's absolutely miserable if your heart rate is elevated. Okay, so if you go to course modules and then click on exam 1 content, then click on the date, week 1, class 1. It's at the top of that one. Oh, because I had it hidden. Sorry, just kidding. Make available. Now it's available. And then it also has some other interesting stuff. Refresh your screen and now it should be there. Sorry. My previous school used Canvas, and I think that Canvas is so much easier to use than Blackboard. So there are times in which I really do really dumb things on Blackboard. So just keep asking, and I'll eventually figure out why you can't see something. So, all right, moving on. We are starting to review atrial flutter. So good times. Hold on, let me pull my big version that I can see up again. Okay, so atrial flutter. So first of all, is our rhythm regular or irregular with this example of atrial flutter? Just glancing at it. Yes, excuse me, it's irregular. We also can see it regular though, or regularly irregular. It is a really fun one. So what's our rate for here? We just go off of our 6-second rule. And counting our R's. Yeah, now, looking at all these times, these poor little P waves are popping up, right? We can actually measure what our atrial rate is. And in this case, our atrial rate is approximately 120, meaning that our atria are theoretically firing, well, they're not theoretically, they are firing in an attempt to have the rest of the heart beat that fast, but only those QRS complexes are what are actually getting all the way through. So our P waves, this is a classic presentation. Yeah, give me 1 second, Jessica. This is a classic presentation of our P waves, a sawtooth pattern. They oftentimes can be called flutter waves or F waves. So if we're looking at our atrial rate, that's how many P's do we have? Because in this case, we actually have more P's than QRS's, right? So here we have 2 P's, 2 P's here, 2 P's here. So we have more P waves than QRS's. So when we're looking and we're breaking it down and we say, do we have a P wave for every QRS? Do we have a QRS for every P wave? Our answer is no. There is at least 1 P for every QRS, but there is not a QRS for every P wave. Nobody's going to ask you, well, what's the atrial rate? We look at what is actually getting through. In this case, the patient has a rate of approximately 170. Where we really start to look is the conduction. And in the case of, whoops, I'm on the wrong slide, hold on. In the case of like this one, where we have every single complex. This is very regular. We have 2 P waves for every QRS complex, right? That's a 2-to-1 conduction, where for every 2 P waves, there's 1 QRS. You may also see a 3-to-1 conduction where it's actually 3 P waves in there. But you really can only do that if you have consistent P waves that you actually can see. And these are beautiful sawtooth waves. Same here, beautiful sawtooth waves, right? These are our T's. They're inverted because of this view. But then we have these P or F waves. In this case, they're flutter. So it's F waves. So we still would look at our R's for our rate, our overall rate. So 1, 2, 3, 4, 5, 6. Our overall rate would be 60. But our atria are firing way more times than that. And again, this is really going to depend on, for our clinical significance, it's going to depend on how our patient presents. I was worried my dog were gonna bark because my husband just got home. But they didn't. I'm really surprised. Okay, so atrial flutter, many times this is associated with some sort of underlying disease. We can see atrial rates as high as 200 to 350 beats per minute. That's where we see those F waves of just trying. It's just pushing out impulse after impulse after impulse. Remember, those are not getting through to the ventricles. So the patient is not actually, the atria are trying that hard, but the ventricles are not. Massive increased risk of stroke with these patients. We can have palpitations, shortness of breath. Again, we're looking at that issue for poor perfusion, right? So that sense of anxiety, confusion, fatigue, dizziness, all of that can be related to some of our manifestations that we can see. And that's all related to that poor perfusion that we see with them. Treatment for atrial flutter, we usually will use medications initially to see if we can get them, or we may do electrocardioversion. And patients who are in it for a long time, or they keep going into it, are a great candidate for radiofrequency ablation, where they actually go in and can see in the atria where all of that firing is happening, and they actually burn those little spots so that, in hopes that the SA node is what takes over and goes back to just beating a normal rate. So we may see that with patients as well. Now, we have a lot of patients who will be in a flutter. We also have a ton of patients that can be in atrial fibrillation. And this is, I put this up there because it's a great demonstration between the two, because they're easy to get confused. We are still dealing with the atria are misfiring, okay? But they present very differently. So in this case, this very first one, are we regular or irregular? This guy we have is irregular. Then we have a heart rate of approximately 50 beats per minute. Can we see any P waves in here? Any discernible P waves? And I can put up another one too. So any discernible P waves we have going on? No, it's chaotic and not discernible at all, right? We cannot even tell what the PR interval would be if we could find a P wave in there, okay? But our QRS, still good. QRS still is within normal limits. It's still narrow. We're still good. Now, clinical significance for this, once again, is going to depend on our patient presentation. Treatment is not normally necessary, but a cardiac consult for sure, especially if the patient's, if it's a new onset. You'll oftentimes see cardiac consult. For brand new onset patients may feel weak, dizzy, again, that palpitation feeling. And if there's somebody who goes in and out of atrial fib, they may or may not be able to tell when they're in it. And ask your patients. That's one of the best things to do. Ask your patients, do you know when you're in AFib? No, never can tell. Or some people are very much like, oh yes, absolutely. I know exactly when I go in AFib. So looking at these issues again, it's a lot of this is related to poor perfusion. So that generalized fatigue, they can feel like they have a rapid heart rate. Now, what's actually perfusing, what those ventricles are actually pushing out, is not what those atria are doing. So fibrillation, they're just kind of quivering up there, trying desperately to do anything with any signal that they have. So there may be a nice pump that gets out every now and then, but really what the ventricles are relying on for blood is what is naturally falling due to gravity. It's not forcefully being pushed by those atria. So poor perfusion signs and symptoms where we have dizziness, weakness, shortness of breath. It all has to do with that decrease in cardiac output. We then have blood just kind of potentially pooling in our atria because they're not forcefully pumping. Same with our A flutter. We end up with that increased risk of strokes and blood clots. So it's a huge, huge problem. Same with our A flutter. Our atria rate could be as high as 350 to 600 beats a minute. You will not be able to see any of that. And really the rate that we're talking about at that 350 to 600 is impulses going out. There's no possible way that the atria could contract at that rate. So it's impulses that may be able to be measured potentially if you could actually see P waves, but really you're going to be seeing that just chaotic fibrillation of just that quivering that's happening. So treatment, drugs. We want to hopefully control the way the ventricles are responding. We want to prevent strokes. And we would like it to eventually go back and to just have that SA node putting out the one signal, right? So in order to do that, we use medications. We may use amiodarone, diltiazem, excuse me. But it really is going to depend on, is that patient stable versus unstable? They may need cardioversion. They definitely need an anticoagulant because, again, we're concerned with that risk for developing clots. They also are a great candidate for radiofrequency ablation or a maze procedure, which is with cryoablation. So they use cold rather than the radiofrequency to burn those areas, and potentially, again, that goal is to have all those other places in the atria that are firing, that those go away, that we quiet them through the ablation, and that the SA node takes over again. Questions about AFib, A-flutter? Okay. Now, junctional rhythms, I mentioned just briefly when we were talking about if it's originating from the AV node. This is where we're going to see it still kind of looks like normal sinus, right? So we have a regular rhythm. In this case, our rate is approximately 40 beats per minute. So it falls right into that junctional rhythm heart rate between 40 and 60. P waves are typically inverted because think about how it's traveling. So it's going from the middle of the heart up to depolarize or the atria, and then down for the ventricles. So we want to make sure when we're looking at those, okay, well, here's these little P waves, we got them, but they're inverted. Plus we have a slow rate. You may have a normal PR interval. However, it could be right on top of the QRS because again, we're having to go up with the stimulus and down with the stimulus rather than all the way down the heart. So really think about, if we're thinking about how that stimulus travels, why it's can be real close to the QRS. QRS is generally normal because it's doing its own thing. It's still depolarizing through the ventricles the way it's supposed to. Again, clinical significance depends on the patient presentation. We see this with certain disease process and some drugs. This is a safety compensatory mechanism of the heart when we're having a junctional rhythm. So we do want to make sure that we are paying attention to what else is going on with our patient, even if in that moment they look beautiful. We still want to be paying attention to what else is going on. What other signs and symptoms do they have? And then here is another example of a junctional rhythm. In this case, this might be a P as we start that QRS, or it's buried in that QRS, depending on what's happening with that patient. But again, we have that slower heart rate. So we can go with that patient having a junctional rhythm. So important things to remember, we do not want to suppress this rhythm because it is a safety mechanism. So we want to make sure paying close attention to what's going on with our patient. Our patient may report the same signs and symptoms of poor perfusion. So generalized anxiety, generalized weakness, dizziness, shortness of breath, heart palpitations. They may just feel off. And we need to further examine what's going on with our patient. If your patient is asymptomatic, we just watch them closely. If they are symptomatic, we use atropine for, and then we need to correct the cause. What's causing this? And then there are times that the patient will have a rapid junctional rhythm, in which case we need to reduce the rate because the cardiac output reduces quite a bit if it's at a junctional rhythm. So we want to make sure that we're paying attention to what's happening with that. Fortunately, that's when we have cardiology involved and we're monitoring, seeing what's going on with our patient. But you may have them say, oh, this is a junctional rate at 100, and you're going, wait a second, I thought a junctional rate was in the 40s or 50s. This is why you can still have that origination of the impulse from the junctional area. And that's why we have that concern. All right. Are we ready for AV blocks? This one is exciting. I would say that these are probably the most challenging for people, which is why I'm going to start with the story of the AV block family. So, for the AV block family, normal sinus, the wife is the P wave, the husband is the QRS, and in normal sinus, the husband comes home on time every night. All right, so that's that idea of there's a P for every QRS, right? For a first degree AV block, the wife, the P wave, sitting there waiting at home. The husband, the QRS, comes home late every night. But he always comes home and it's always at the same time every night. So with an AV, first degree AV block, the only thing that's different is we have a prolonged PR interval. And we're going to go step by step, don't worry. This is just kind of an overview. Second degree block, type 1 or a Winky block. The wife is waiting at home, the P wave, they're waiting at home. QRS comes home later and later and later every night until one night he doesn't come home at all. To be an AV, a second degree AV block type 1 or Winky block, the QRS needs to be late at least 2 in a row before it dropped for this to be considered a pattern. Okay, so P wave is always there. The QRS is later and later and later, and then it drops. Second degree AV block type 2. Here's the P wave. She's there. She's hanging out. She's waiting. Sometimes the QRS comes home. Sometimes it doesn't. When he does come home, it's always at the same time. Okay? So you'll have a P wave. She's always there. P waves are, they march out, is how we label it. They're consistent, right? QRS, this is where we find, is there a P wave for every QRS? Is there a QRS for every P wave? This is where we look at that, okay? This is considered a more serious condition than type 1, usually requires, they label it counseling or pacing. And then a third degree block, the wife from P wave is no longer waiting at home. She is doing her own thing. She is marching to the beat of her own drum. QRS, he may or may not come home. He's marching to the beat of his own drum. They are on separate schedules. There is absolutely no relationship to them at all. Okay? No relationship between what P is doing and what the QRS is doing. Each spouse has a regular individual schedule, and this does require temporary or permanent pacemaker. This is a very dangerous rhythm. Okay, so now let's go into each one. So here, this is what they look like. So first degree AV block. Are we regular? Regular or irregular? Oh, it's just marching out, nice and regular, right? But look here. So then we do our rate. 1, 2, 3, 4, 5, 6. 6-second strip. Rate is 60. We have P waves, right? There's a P wave. There's one. There's one. Yeah, they're all there. They're upright. They're present. They're normal. There's one for every QRS. This is the one where all we see is this prolonged PR interval, right? Right here. QRS, it's still narrow, and there is a QRS for every P. This minimal clinical significance. What we really can look at is that the impulse from the SA node takes a little bit longer than normal to get to that AV node, and then to then distribute out, right? So if the patient is not symptomatic, this could be their baseline. We do see it with increased age, increased disease states, and some drugs can cause that prolonged PR. Patient is typically asymptomatic. They don't have it. They don't notice it. And generally there is no treatment, but we do monitor for changes in heart rhythm. It can be a precursor to more serious types of blocks. But this initial one is just monitoring the patient. So here's another example. Look at how long that PR interval is. But man, those P's are marching out. QRSs are there. Everything's beautiful except for how long that is, right? Here we have 1, 2, 3, 4, 5, 6. Another heart rate of 60. QRS is good. We have a P for every QRS, a QRS for every P. All that looks good, right? Any questions about first degree AV block? Yes. Yes, the rate and rhythm is regular for first degree block. The only thing that we see different is that prolonged PR interval. Okay. Now we have a second degree AV block type 1, Winky block. So this is the progressive lengthening of that PR interval until the QRS is completely blocked, okay? So in this case, here's our P. Well, here's our P first. So pretty normal actually right there. We get a little bit longer PR. There's a P. Oh my goodness, it's taking forever to load. Okay, so let me address, and you guys actually were awesome answering for each other. So, it depends on how we're looking at the electrical activity from the heart. We have that isoelectric line, which will always be there, but depending on which lead, and I should have uploaded it. There's a great picture. It actually shows a bunch of arrows based on the leads of how it's looking at the heart, and how that electrical impulse is traveling through. So for you remember, and we look at, okay, well, if it's a P wave, it originated in the SA node, then we expect it to travel, go through the atria, get to the AV node, bundle of his, then down through the ventricles and bundle branches, and then Purkinje fibers, right? So we see that progression of that electrical impulse based on where we look at these is how we show up on the 12 lead, when I grab just sections of an EKG strip, sometimes I'm grabbing, we typically look at them from V2 because that's what we're used to looking at, but we may grab something because it shows a better distribution of the PR interval, right? So it just depends. And you can actually change them on monitors. It just typically is in lead 2. So don't get freaked out if you see an inverted QRS. The only time that it's really quite particular that we need to know is with those ventricular rhythms, or sorry, with those junctional rhythms where we would know that our P wave was inverted because of how the impulse is traveling back up the atria. And I do love the, who put the explanation of the surfer? Was that Ben? Somebody put the explanation of the surfer.
Yeah, it's Ben.
That's a great way to look at it. So I had not heard that one. So that's a great way. And yes, I absolutely will post this recording. So essentially whether or not it's upside down or up or upright, it really it's depending on how we're looking at the electrical activity. And do not let an inverted QRS throw you off. Still break it down in each of those steps. Do you have what? Do I have a regular or irregular rate? Do I have what is actually my irregular rhythm? What is my rate? Don't throw it off. That's why I tried to put on here strips that showed a variety of different ways that we may end up looking at them, because I don't want, like this one, I don't want you to go, oh my gosh, well, that can't be a first degree block because those are upside down QRSs. Okay. We're still looking, do we have a P for every Q or QRS? Is it regular? Is it irregular? Do we have a, so that's what I want you guys to be paying attention to. Okay. Let's see. The other question was about type 1 versus type 2. First degree blocks do not have subtypes. Second degree, we have a type 1 and type 2, and then third degree block does not have a subtype. Okay. I think I was here. Okay, there's our blocked. Any questions since I got kicked out and brought back in and all of that? Did I miss any other questions?
I have a question.
Yes.
I think I was worried about the inverted QRS as well because we were looking for the inverted P waves. So I didn't know if there were other inverted things that we need to look out for, and if it's like which is significant, or like for example the QRS where it's not a big deal.
Not for the purposes of this class. There are times when we look for an inverted T, or we look for, but we're always going to look for those in places where we should have upright and it would be different. So if we're in lead 2, which is what we normally see, our typical EKG pattern, and we were to see inverted there, that's when we have other things, but that's advanced, like you're working on a cardiac floor. So it is not necessary for the purpose of this class. I just don't want you guys to be thrown off because these two look like very different rhythms, but they're really just looking at the same rhythm from a different point of view. So that's why you take those 5 steps to break it down to decide what type of rhythm it is and not get thrown off by inverted QRS, or is it above or below the isometric line? I don't want you guys to worry about that for the purposes of this course. The purpose of this course, don't panic about that.
So for the purpose of this course, are we also looking out for inverted P waves, or were you just mentioning that, but we're not?
I don't think I have a test question on junctional rhythms, but the inverted P is very specific to a junctional rhythm. But I don't remember, I don't think I have any questions about junctional rhythms on the exam. I'll have to double check, but I don't think so.
Thank you.
Okay. Okay.
I'm sorry, did you say that this is going to be posted as recorded? Joy said that she's not able to get back in yet.
Yes, absolutely. I'm going to. Let me try to.
Yeah, she said that she's trying to get in and it says that the page is unresponsive.
Let me try to invite her in and see if that helps. That may help. Sometimes you have to work around Teams. Let's see if that works. But yes, I'm absolutely going to post this. And then we also, like I said, I'm going to be running the crash cart / medication section in lab on Thursday, and any other things that you guys want to review. If there's anything that's not clear, we can review again, and I can pull out strips then too. So, okay, 3rd degree heart block. This is by far the worst. We have no correlation between what the atria are doing and what the ventricles are doing. Interestingly, the P's will march out as regular and the QRSs will march out as regular. So when you look at it, it can look, this one actually looks like potentially just this patient is in bradycardia, right? When you just at very first glance, which is why you have to utilize our trick of let's break this down. All right. So do we have regular versus irregular? Well, in this case, we have regular P's and regular QRSs. Same with this one. Look, it's all marching out just beautifully, right? Beautifully. Sometimes the P's will end up buried within the QRS, so you may not, you might miss one, but all the rest of them march out before and after, so you're like, oh, a P would be here. And you're like, okay, that still would be regular, okay? They are disassociated from QRS. The top part of the heart, all the atria, are not talking to the ventricles, okay? So they're doing their own thing. This is a very bad rhythm, okay? The QRS complex is generally wide, although in this case it's not wide, but here we have a wide QRS because the ventricles are creating their own impulse. They're like, man, we're not getting anything from the atria. We need to do it ourselves, okay? The absence of the conduction between the atria and the ventricles causes severe cardiac compromise. The output, cardiac output, kaput. Okay, there's nothing that is saying that we've got good contraction in the atria, good contraction in the ventricles, because there's no coordination between them. It's typically very slow. In this case, we have 40. This case, we have 30. And it is a bad rhythm. The treatment for this is a pacemaker. This actually is what my mom had. She woke up feeling lightheaded, dizzy. She vomited once. She was short of breath and told my dad she wasn't feeling well. And he calls my sister, who's a cardiac nurse, and she says, please, for the love of everything, call an ambulance. She called an ambulance. She was she was in a complete heart block with a rate of about 35 to 40. The paramedics told her, ma'am, you have to go to the hospital. And she says, oh, my husband can drive me. And they refused to let her refuse treatment, refuse transport, because they did not think that she was perfusing well enough to make an educated decision about her health. So she, by the time she got to the hospital, she had a rate in the 20s to low 30s, and went emergently to the to cath lab for, and then eventually for a pacemaker placement. So very bad, very, very bad. Your patient will not look good, and will not feel well either, because nothing is functioning the way it's supposed to. Sazi, go ahead.
Is the rate usually counted from the QRSs or the P waves for this one?
Your rate is counted from your QRSs. So if you were to take the pulse on the patient with this rhythm, right, this strip, what you would be feeling would be a pulse of about 30. So what you actually feel is that the push of blood out the ventricles. That's what you feel with a pulse. So if you are looking at this on a monitor and you're not sure like what's actually conducting and going all the way through, check a pulse. You will probably realize that you're coordinating with your QRS complexes. So when we're checking and we're looking at a rate, it's the R to R is how we calculate our heart rate. Shay.
I've seen this a lot too in confused patients that accidentally overdose on their beta blockers. Like they'll forget that they took it, and then they'll be like, oh, I forgot to take my medicine, and then they'll go take it again, and they'll go take it again, and then daughter will come over and they'll be like, I don't feel good, and then because they took too much of their beta blocker.
So we actually will see second degree type 2 more with beta blocker overdoses, because it's doing exactly that. It's blocking. So we're blocking that QRS, but it can rapidly progress from this to this. So we always want to keep in mind that this is actually a progression for these AV blocks. They're actually a progression. So when you have this, a first degree block, pull it up, we have a first degree block, not so bad. But as we move through, we are progressively getting worse to ultimately, there's no communication between atria and ventricles. They're not perfusing, and they will look poor, and their outcomes are poor if it's not dealt with as quickly as possible. All right. Let's take a quick break. I need to get some water, and be back at 3 o'clock for the last little bit, and then we'll do a bunch of practice ones where I'll just put one up and you guys can tell me what you think it is. So see you back in at 3 o'clock. All right, here we go for the last call. So, premature ventricular contractions. Now, these are extra beats. They can look wide and bizarre. They can be kind of regular. So here we have a couplet where we have two PVCs right in a row. This person then went into VTAC. So they can indicate, hey, there's some irritation going on. There's something happening with the conduction that is not allowing conduction to happen properly. So it usually has a broad or wide QRS complex, and it looks different than the rest of your QRSs. Okay. They don't march out with your P's. They don't march out with T waves. They're just kind of boom, thrown in there. Typically, there's a bit of a pause as things kind of need to reset. And then you go back into whatever rhythm their underlying rhythm is. So you can have a PVC with any type of underlying rhythm, normal sinus, sinus Brady, sinus tach. You can have PVCs with AFib and a flutter. There's all of a sudden there are these random QRSs thrown in there. They have different clinical significance depending on how they are presenting. So they can be associated with the use of stimulants, electrolyte imbalances, hypoxia, underlying coronary artery disease. They are typically not harmful if they're random and there's just one, and then we have, 15 beats of whatever their underlying rhythm is. Where we start to have issues if we have couplets or they are in bigeminy, or trigeminy, which in this case, bigeminy is every other beat is a PVC. So you can see every other beat. We have a normal, normal, normal. And then PVC is every other beat. Trigeminy is every third beat. We don't go higher than that. So you have kind of random thrown in. PVC. These are from different sites within the ventricle. They look different from each other and they look different from our QRS. That's how we know that they're coming from different areas of excitability. These are all the same. Each one of these PVCs look exactly the same, right? So we want to be looking at, do we have them coming from all the same sites? Again, this PVC looks the same as that one. Okay, good to know, right? Frequent PVCs can give the patient the sensation of palpitations or a sense of their heart skipping a beat. If patients have an underlying predisposition to other rhythms, so whether it's Wolff-Parkinson's White, they have ischemic heart disease, they have a history of AFib or A-flutter, PVCs can trigger them to go back into that rhythm. So we do pay attention to them, but if they're just random and the patient is presenting fine, then we're good. Treatment for PVCs, we want to correct the cause. So if they have some strange underlying, I don't know, they're dehydrated or they're hypoxic, fix it. we should see an improvement in their PVCs. We also use IV beta blockers, lidocaine, or amiodarone, depending on how the patient is presenting. All right, so we have a question here. So if a patient has been discharged with a diagnosis of acute myocardial infarction and has a cardiac rhythm of sinus brady with 6 to 8 PVCs per minute, the pattern that the nurse recognizes as the most characteristic of PVCs is it's an irregular rhythm, an inverted T wave, a wide and distorted QRS complex, or an increasing long PR interval. So how do we describe what is a PVC? What do you guys think the answer is for this one? Let's look back at our PVCs here. What do these look like? Yeah, every last one of these, wide and distorted QRS. Wide and bizarre. So it's not just that it's irregular, because the PVC will cause the rest of the rhythm to be irregular because there's this random extra beat in there. But to actually describe what a PVC is it's a wide, distorted QRS complex just thrown in. All right, here comes the fun stuff. VTach, ventricular tachycardia. Now, we do want to do the same kind of breakdown. Is our rhythm regular or irregular? My goodness, this is a strangely regular, right? If we're counting QRS complexes, 1, 2, 3, 4, 5, 6, 7, 8, 9, give it a heart rate of 90. Do we have P waves? Not that we can see. Nothing in there, right? PR interval, can't measure that. Our QRS here is that wide and bizarre QRS. Okay. This is a severely compromised patient with severely compromised cardiac output. What does your patient look like? VTach can have a pulse. It can quickly convert to VFib without a pulse and lead to death. VTach is one of the 2 shockable rhythms that we see and will shock, VFib and VTach. When we see VTach on a monitor, it is essential that we immediately assess our patient to determine symptomatic, asymptomatic, do we have a lead loose? What's going on with our patient? Okay. So what would be the very first action you would do if you saw a patient with this rhythm? What are we going to do?
You're going to ask them to bear down and you're going to get a 12 lead. Assess the patient.
Even before that.
Symptomatic.
Fozzy's on the right track. Yeah, we want to assess airway, breathing, circulation, and their LOC. We got to check right away. Do they or don't they have a pulse? Okay, we have to know that. Assess the airway, breathing, circulation, and level of consciousness. Now, these are all coming from the same area. Every last impulse is coming from the same area. You can have VTach where you'll have sections where it will look different. And so this is considered monomorphic, meaning it's all those impulses are coming from the same spot. VTAC with torsades de pointe. We don't call it that so much anymore. Torsades is easy to remember. This is polymorphic, meaning they're actually coming from different areas. When we have a patient, the torsades de pointe actually means twisting of points in French. So it kind of has this weird, like, if you look at it a longer strip, this will repeat. So you have narrow and it'll get wide and then narrow and then wide. It's a very interesting rhythm to see. Patients may or may not have a pulse. We still have that wide and bizarre QRS. The rate is fast. It's irregular. And our patient is absolutely considered unstable. Once again, we are looking at somebody who has severe cardiac output. Their cardiac output is just in the trash can. Mag sulfate is often given, and then we treat this like VFib. Mostly because we have so many different points of entry for how the electrical stimulus is coming through, that it really is more, it's closer in the behavior and the mechanism, like what's actually happening to the heart, to VFib than it is to VTAC, because it's having so many. It doesn't have anything organized. It's just, they're just kind of quivering like they do with VTAC, or VFib rather. So VTAC, this is associated with patients with known heart disease, prolonged QT syndrome. So remember, we've been talking about all of this, you know, these segments and these, you know, is our PR in the right way? Is our QRS okay? Well, now we're looking at that QT segment. So let me pull up. Just look here. So QT is going to be from the start of the QRS to T. Prolonged QT segment means that we have the stimulus is not getting through the way that it should be. And there's many things that can cause prolonged QT, including medications. Some common ones that we use all the time: Zofran, amitriptyline, Z-Pak, Seroquel, Geodon. All of them can cause prolonged QT syndrome, and they stack. So it's not like, okay, I'm going to give you Zofran, you're going to have prolonged QT, and then we give you amitriptyline, and you already have the prolonged QT, so it's just going to be the same. No, it actually can make your prolonged QT even longer. The longer the QT segment, the more likely they are to go into an unstable rhythm like VTAC or VFib. So we want to always be keeping that in mind. Kazi.
A while ago, you were saying something about mag sulfate as a treatment.
Oh, I can't hear you.
Was before. Oh. Hello? Oh.
Anybody else hear her? Sorry. Sustained VTAC causes severe decrease in cardiac output. Yep, mag sulfate is one of our treatments. Can cause hypotension, pulmonary edema, decreased cerebral blood flow, cardiopulmonary arrest. We absolutely can see this patient completely decompensate. They are not stable. I'm wondering if it's my internet. Let me try something real quick.
I think she realized
Hello?
maybe why it sounds funny.
Is
You
this
sound
better?
Is that any better now? Does that sound better?
I can hear her now.
Yeah, we were talking about Sazi.
Okay.
If someone can just relay it to her, but I just saw that
Oh, I
here it
can
says
hear you now.
sustained VT causes. Oh, okay. I saw that sustained VT can cause severe decrease in cardiac output. And so I didn't know if mag sulfate would be something to be used before they have sustained ventricular tachycardia, since it could cause hypotension, or since they could have hypotension.
So part of it's going to be depending on how our patient is presenting, what's their underlying cause for it. We do use mag sulfate. Sometimes it's all happening so quickly that we're just like, okay, let's push this, push that, let's go. Especially if they're coming into the ER already in VTAC. If we see them progress from, frequent multifocal PVCs to VTAC, we may have already tried mag sulfate to simmer down the multifocal PVCs if they're doing them very, very frequently. So it's really going to depend on how our patient is presenting. It can be used as a primary treatment. But if our patient is unstable and or pulseless, we shock. This is a shockable rhythm. So that may be the first thing you do as opposed to waiting for mag sulfate. Some major causes should be identified, and we need to correct that. So why did they end up this way? Is it hypoxia? Did they have a cardiac event and they have ischemic heart and now have gone into VTAC? What underlying cause can we identify and treat? VTAC with a pulse is more stable than pulseless, obviously, and we treat with antidysrhythmics and cardioversion. Pulseless VTAC is CPR with defibrillation. All right, VFib. This is just total chaos. They do not have a pulse. The heart is just quivering. There is nothing. The rhythm is chaotic. The rate is chaotic. There's no P waves. There's no PR interval. There's no QRS. There is nothing that is identifiable as, hey, this is what's going on. All right. So this patient, this is an emergency. The patient should immediately be assessed, pulse or no pulse. If this is the true if this is the true rhythm, the patient will not have a pulse. It is associated with an acute MI, acute heart attack, other forms of ischemia, chronic disease states, cardiac procedures. So if we go in to do a cardiac ablation and they accidentally send a patient into VFib, that can happen. The patient is unresponsive, pulseless, and apneic. They are not breathing. They do not have a pulse. It does need to be treated immediately with CPR, ACLS, rapid defibrillation, drug therapy, including epinephrine and amiodarone. All right, question for you guys. So, a patient in the coronary care unit develops VFib. What is the first action a nurse should take? What's the first thing we should do for a patient with VFib? Of these options. B, absolutely. Yep, so we want to be looking at this patient, initiate CPR, and those steps, just like we do with all of our CPR classes, check for a pulse, get help, get the defibrillator. So immediately start our start CPR, because this patient does not have a pulse and they are not breathing. All right, so then we have asystole. So asystole is the complete lack of any electrical activity. There's no ventricular contractions, there's no atrial contractions. The patient is unresponsive, pulseless, and apneic. This must occur in more than one lead. So when we go back to that 12 lead, you can't have asystole in just one of those leads. It has to be in more than one. This is poor prognosis. We do not shock asystole. In spite of every movie, every TV show, and the patient flatlines and they go and shock them, we do not shock asystole. Please, for the love of everything, we do not shock. They need immediate CPR, ACLS measures, epinephrine, intubation. This is a poor prognosis. Now, we do have times where somebody may look at this rhythm down here and say, oh, that's fine VFib. That is not for you to worry about. Let the physician decide who is running the code. Let them decide if it's fine VFib and they want to shock it or not. But asystole, we do not shock. Now we can have something called PEA, or pulseless electrical activity. This is where we still will see electrical activity coming across our EKG. Sometimes it's as good as normal sinus. But when you check for a pulse, there is no associated mechanical activity. So we have, wow, look at this rhythm. And you look at your patient and you're like, they don't have a pulse. Prognosis is not great. It's very bad. If somebody has PEA, we want to know what's the underlying cause, what's happening. Again, was this an acute MI? Did we have sustained VFib or VTAC and then we shocked them and they went into this? That can happen. But if we can identify the underlying cause and correct it, that increases their potential for a better outcome. When we look for PEA causes, we look for our H's and T's. So we can have PEA associated with hypovolemia, where we lack volume for some reason. Did they bleed out? Have they, are they septic and hypovolemic because of that? Hypoxia. Hypoxia is always a great one. Are we actually perfusing? Do we have the ability to perfuse? The heart is especially irritable when it comes to imbalances in our electrolytes. Hyper and hypokalemia, big problem for our heart. Hypoglycemia, hypothermia. You may have heard the term, somebody's not dead until they're warm and dead. This is why. Acidosis is another thing that we can see. For the T's, so we go, what are H's and T's? So have they been exposed to a toxin? If so, what is it? Can we fix it? Do we have an antidote? Cardiac tamponade, that's where the heart does not have the ability to pump, because the mechanical ability to pump, because something is constricting it. Usually they've bled into their pericardium and it is literally squeezing the heart so hard. They may still have electrical activity. if we can relieve that tamponade, they may get mechanical activity back. Have they had a thrombosis, whether that's an MI or pulmonary one? Tension pneumothorax, again, that's going to be very similar to a tamponade where that pressure is just not allowing the heart to pump. So we could still see that electrical activity, but not mechanical. And then have they had trauma? Now, if they've had trauma, we probably also have hypovolemia potentially associated with that. So can we correct that to give that heart what it needs to pump and for that electrical activity to do something? Treatment, CPR. We do not shock PEA either. So CPR followed by intubation, IV epinephrine, and then our treatment is going to be based on what are these H's and T's. Have we found something that we can correct to potentially fix and make us all good, right? All right, any questions about that? We can also have something, sudden cardiac death. This is somebody just dropping dead because of a cardiac cause. Now, in my mind, when I hear that, I'm like, of course it's a cardiac cause. You can't die unless your heart stops beating, right? There are people who have underlying cardiac issues that they don't know about. The football player that they did CPR on, he very well could have been sudden cardiac death. Somebody was there, intervened rapidly, started CPR, and corrected his problem, right? So this is something that we see across all ages, but it's really going to depend on what's going on with our patient, what sort of history they have. They may have none. This actually happened to my mother also, the same woman with the pacemaker. She just decided that she woke up again in the morning not feeling well, told my dad, and when my dad called 911, they told her to lay her down. She said, if you lay me down, you will kill me. And as soon as he laid her down, she stopped breathing. She stopped having a pulse. My dad immediately started CPR. EMS got there. They defibrillated her twice, intubated her, and she's still alive and with us to this day. Absolutely blows my mind. She has no reason to be alive. She keeps pushing the envelope when it comes to just how far can she take this. So you can see sudden cardiac death with a lot of different cases. All right, here's another question, and then we will jump into practice rhythms. I'm so excited. Somebody had a question. Well, I saw a hand and then it went down.
It was me. I was just asking if how much of this exam is going to be meds?
I think there's like 2 med questions, but they're very general.
Because you said earlier that 75% of the exam was going to be not rhythms themselves. So is it going to be more of like conduction pathway questions?
No, I did not say that.
Oh, I'm sorry. I misunderstood you then.
Yeah, if I said that, I'm very sorry. That was not my intention. No, there are rhythm strips on there. There is, there's a couple questions, like if you were to find a patient with, in this rhythm, what would your first action be? And if there's a rhythm there. So, you know, are you gonna check for a pulse? Are you gonna give them cake and ice cream? You know, it's not that obvious, but so there's a couple like that. And I'm gonna have to look. I will double check before Thursday And if there are specific drugs that I want to make sure that we cover, I will address them in lab on Thursday. To
Okay,
make
great.
sure that we've gotten into that. So remember to do that. And then if there's anything that didn't get covered that I think is not adequate enough, then I'll go over it on Thursday in that station that everybody will go through. All right. So for this one, client in sinus Brady with a heart rate of 45 and a blood pressure of 82/60 reports dizziness. Which intervention should the nurse anticipate will be prescribed? So what do we think we're going to do for this patient? So first of all, with a heart rate of 45 and a blood pressure of 82/60 and dizziness, are they symptomatic or asymptomatic? Let's break that question down. Yes, absolutely. This patient is 100% symptomatic. So we need to do something about that, right? Now, digoxin. Like it, don't like it, want to use it, don't use it. What do you guys think? May not have done this yet. Because I think you do that. Yeah, no, we don't want to use digoxin. You're right. It will actually slow the heart rate down. So let's not do that, right? Defibrillation. Do we defibrillate sinus Brady? No. The two we defibrillate are sinus tach, VTach and VFib, not sinus Brady. VTach and VFib are the only things we defibrillate. If a patient is symptomatic, are we just going to continue to monitor them and be like, yeah, okay, sucks to be you? No. No, there's a good chance this patient will end up being paced. So prepare for transcutaneous pacing is, so the answer is 4 on this one. All right, you guys ready for practice rhythms? Okay, so first off, regular or irregular? Regular, yep. What's our rate? Yep, regular and a rate of 80. We have P waves. P waves look good. Present for every QRS. Our PR intervals. That looks within normal range. QRS, it's narrow, upright, and there's a QRS for every P. So what do we think this is? Absolutely, normal sinus. We are not doing ST elevation. Don't be looking for zebras when we're talking about horses. Don't make it harder than it needs to be, Ethan. All right, so normal sinus, yep. All right, here we go. Here's our next one. So using our breakdown, regular or irregular? Yeah, pretty regular. We got a rate of 70. P waves, normal, right? We have they're upright. We have a P wave for every QRS. QRS for every P. What's our PR interval? It's a little long. Yeah. All right. So if our PR interval is long, what would this be? First degree AV block. Yep. Excellent. Excellent. All right. Here's our next one. Regular or irregular? Pretty regular. Yeah. What's our rate? All right. 150-ish. Yep. So P waves. Kind of hard to see because they're sort of with RT. Kind of at the end of RT here. But they're there. They're regular. QRS complex. We got one for every P and one P for every QRS. What do we think this is? So this one they're actually labeling as SVT. I would accept either sinus tach or SVT because, and let me tell you why. We don't show the patient in a slower rhythm before they go into SVT. We do think about SVT being greater than 150 beats a minute. We're right at 150 beats. I will not put a rhythm on that makes you go, well, it could be this or it could be that. It will be obviously SVT with a rate of like 180 versus sinus tach where the rate would be like 130. I'm not going to put it to where you guys are back and forth trying to decide. And this is why cardiologists get paid the big bucks, because we look at this going, it's regular, it's fast. What does my patient look like, right? These are the things we want to be thinking about when we're looking at this. Okay. How about this one? Regular, irregular? What's our rate? All right, we have P's. These beautiful P's are right here. Yep, beautiful P's, a P for every QRS, QRS for every P. Yeah, sinus tach. Actually, in this case, because our rate, 170, we're gonna go with SVT for this one. Because we have that higher rate. All right,
so
how about this one? Oh, go ahead, sorry.
So if that exact strip is on the exam, it's not going to be sinus tach, it's SVT because of the rate?
Yeah. Yep.
Okay.
So like with this one, that slower at 150, like I said, I'm not going to put something like that, but when it's
I was just curious because, never mind.
No, you're okay. So again, part of this is we look at sinus tach as being up to about 150. Anything higher than that is where we start to look at SVT, supraventricular tachycardia. Because those are the rates that we can see in the 170s, 180s, 190s, over 200. The PSVT, we look at the paroxysmal part. We actually would see like a small section of a slower, more normal rate, and then into a rapid rate, and then maybe back down to a slower rate again if they can quickly convert.
Right.
If they're not sustaining that.
Exam.
Am I frozen again?
You're not frozen for me.
Oh, okay. So that's what we're looking at, that difference. So we're really looking at that 100 to 150 being, let's just call it sinus tach, so long as we have P's and QRS's and everything's good. Greater than 150 is where we start looking at SVT. All right, and that's for the purposes of the exams. That'll help clarify. All right. How about this one? So, regular, irregular. Oh, somebody just jumped straight to second degree tech 1. And what's our rate? 1, 2, 3, 4, 5, 6. We have a rate of 60. All right. So another one that can be helpful, another saying that can be helpful is longer drop. Now you've got a winky Bach. Sometimes people need like little things. So longer drop. Now you've got a winky Bach. So second degree. What's up? Second degree type 1. There's tons of like little videos on how to remember different blocks, depending on how your brain works, if that helps. All right, what do we think this one is? ETAC. Absolutely. So we have, it's regular, weirdly, right? It's about 210. No P waves. No PR interval. QRS is wide and bizarre. And our treatment of this patient is, what do they look like? Do they have a pulse? Don't they have a pulse? All right. Check them over. All right, how about this one? Regular versus irregular. Regular. And our rate? Yeah, sinus Brady. We got those P waves. We got a P for every QRS, QRS for every P. Sinus Brady at a rate of 40. All right, here comes our next one. As soon as I can get my thing to go over there. Come on. How about this one? Regular, irregular. Look at how beautiful those little flutter waves are. Rate of approximately 100. Atrial rate's about 120. Those classic sawtooths. Saw teeth. Those F waves are pretty consistent, man. Those guys are just marching out there, right? QRS is still narrow, so we have atrial flutter. All right, how about this guy? So, rhythm, chaotic, great, chaotic, no P waves, absent PR interval, absent QRS, gives us VTAC, VFib rather, sorry, I was reading something else. So remember, VFib will not have a pulse, so you have to check the pulse on your patient. Make sure that it's not just some loose lead or something, because it'd be terrible if you went up and tried to shock somebody who just had a loose lead. So assess your patient, determine if they have a pulse. If this is a true rhythm, the patient will not have a pulse. Okay? It is a lethal rhythm. VFib means you defib. So VTAC, let's look back at our VTAC. Look how beautiful and organized VTAC is. VTAC tends to be more organized, where you actually have a pretty regular rate that potentially you could march out if you needed to, which is why we end up with our VTAC patients having a pulse, because a lot of times they'll go from their baseline rhythm, whether that's normal sinus, whether that's AFib, A flutter, and then they start throwing PVCs. Those PVCs become more frequent, and then we end up in VTAC. Versus this is just chaotic. Chaotic rate, chaotic rhythm. There's nothing that's discernible in here. That makes sense? Okay. All right, how about this one? So regular versus irregular. So this is where we get into that. The ventricular rhythm is irregular because we're missing a QRS here, right? But our atria just, man, they just keep putting out those P waves just like they're supposed to. And what's our rate? Our rate on this one, yep, 60. So our P waves are normal, but some of them are not followed by a QRS complex. So this is where we go, hey, do we have a P for every QRS and a QRS for every P? This one here looks like we're missing a QRS. The PR interval, though, remains the same. Looks good all across. We just have that random missing PR interval or missing QRS. And our QRS is still upright and narrow. So we have second degree type 2 or a Mobitz 2. How about this one? Regular or irregular? Irregular, yeah, absolutely. What do you think our rate is? This is where we get that very chaotic atrial rate, fast and chaotic. So we're about 130, 140, depending on how you're counting, if you count that one or not. P waves, not discernible. We cannot say which one is a P wave, which one is the P that's getting through to that QRS. Can't tell what the PR interval is, but our QRS is still narrow. So yep, AFib. What about this one? Asystole. This is really telling us there is no electrical activity that is seen on that cardiac monitor. The very first thing we want to check is, are they unalive? Do they have a pulse? All right. We do not shock this rhythm. Remember, this is not an episode of Scrubs or Grey's Anatomy or any other medical show you can think of. ACLS protocol for this patient with after you've checked their pulse. High quality CPR provided their full code. What about this one? So, third degree, man, you guys are throwing that out there. So things to keep in mind with this third degree. Look at how beautiful these P waves, they just march right on out, right? They're like, hey, I'm here. QRSs doing exactly what they're supposed to do, right? But they are not coordinated in any way, shape, or form. Heart rate's about 30 because we go based off of our QRSs. Remember that absence of conduction between the atria and the ventricles causes severe cardiac output compromise. Okay, we have to fix this. This patient looks like garbage. So yep, third degree heart block. All right, what about this guy? Regular versus irregular. Second degree type 2, yeah. So our P waves march out and the PR intervals within normal limits, but we lose our QRS complex. So second degree type 2. All right, what about this one, guys? VFib. VJib. Nope, not VJib, but VFib. Or would it be VGib? It's like a GIF versus a GIF, right? All right, how about this one? Second degree type 1, absolutely. So we have normal PR, a little bit longer, a little bit longer. There's our P, whoops, no QRS. Longer drop. How about this guy? This one is actually a first degree block because that PR interval is long. Now, again, this is one of those where you probably would need to get out your calipers and measure, is that PR interval, especially, you know, are we right on the borderline? I'm not going to do that for you guys. It's going to be a nice long PR that you're going to be able to tell from as soon as we do it. So, but yes, this is a first degree AV block. What do we have here? VTAC it is. They're actually calling it multifocal VTAC because we do see such a wide variety of attempts at a rhythm. It does sort of fall. I mean, you could potentially say torsades. I would take torsades because we do see some widening and then narrows, widening and then narrows. So I would take torsades as well. Again, this, if it's going to be torsades, it's going to be obvious. Ethan, do you mean like ST elevation kind of stuff that we would see on strips? Is that what you're asking? We will talk about ST elevation MIs when we talk about MIs, but not in the sense that I'm going to give you guys, here's a strip, tell me if this is ST elevation or not, because that is not how, that's not how we function as nurses. But we will talk about the implications of an ST elevation and what that looks like, but not like you need to be able to identify this, if that makes sense. So when you're looking at the presentation of this strip, we have pretty clear indications of electrical activity. And we have it getting, so it's narrow, then we have it getting wider and then narrow again. And that is where we really would call it the torsades. It's a little bit more, the reason why it's so chaotic is because it's multifocal VTAC or torsade. So it's coming from different points. The electrical impulse is coming from different points. Whereas when you look at VFib, it is like, it's just quivering there. So when you, it's very similar to when we look at AFib versus a flutter. A flutter is a lot more coordinated. It can still look, we think about the classic A flutters, these beautiful F waves, and it looks like, you know, these waves, but you can have them not especially organized, but that underlying base is just quivering. And that's when we're thinking mechanically about the rhythm, VFib is just quivering. There's nothing there. There is potential for this to be organized enough to still be putting out enough of an electrical impulse to have a pulse of some nature. If it's great, probably not. Now, are we going to sit here and say in the middle of a code, is this VFib or VTAC? Make the decision right here, right now, and you have to treat it. Well, guess what? The treatment for VFib or VTAC is defibrillation. So we're okay if you're going, I don't know if that's VFib or VTAC. Okay, check your patient. Do they have a pulse? Are they stable or unstable? If it is truly VFib, they will not have a pulse. So again, for purposes of testing, it will be a very obvious VTAC, like this one, to where it's very clear, it's very obvious, versus VFib. This is considered fine VFib. Somebody may say, oh, well, that could be asystole. It could be. There's potentially some not organizational, there's potentially some electrical happening. So, but for the purposes of the exam, VTAC will look more like this for you guys, as opposed to, oh, see if you can tell me which one this is. Okay. All right. What about this guy? This one's a fun one. Shay, you are on it. So
I don't know if this
see these.
helps anybody, but something to help with between second degree type 2 and third degree is your PRI doesn't get shorter. And then a lot of times it will be like long in the QRS before and then short on the next one. And then that's how you can tell that they're marching separately, sorry.
Yeah. So we do see our tiny little P waves in here, right? And these guys are they're just doing their own thing. They're marching to the beat of their own drum. Same with our QRSs. Now, remember, this is only a 6-second strip, so we only got 2 QRSs in this, but they're as regular as you could tell. Now, if you're looking up at a monitor, you'd be able to tell a lot better if they were marching out. I have like 10 more strips. Do you guys want me to keep going? Yes, no?
Yes, please.
Okay. All right, how about this one? So remember with a flutter, we get pretty nice organized atrial F waves. So in this case, we actually have this underlying right here. This is all just fibrillating. So this is AFib. We have our QRSs. There's unorganized P waves going on here. We think there might be P waves in there. Whereas with a flutter, you actually can see those P waves. They're just a lot faster than the rest of the rhythm. All right, how about this guy? Yep, sinus rhythm with a PVC. So everything else looks beautiful. We have a nice rate, a nice rhythm. It's very organized. We have P's for every QRS and a QRS for every P. Then we just have this random wide and bizarre QRS thrown in there. That is a PVC. Just look right there. If it's just one and our patient is not symptomatic, we don't particularly care. All right, how about this guy? This is a classic example of torsades. VTAC, multifocal VTAC is another way that people put it. And really we see this beautiful, like nice big, and then it kind of goes small, and then it progressively gets bigger, smaller, bigger, and then you'll see that across. PVC versus sinus rhythm with the PVC. When it comes to something like this, you would want to identify that it is normal sinus with a PVC and not just PVCs. So Whether you say PVC with normal sinus or normal sinus with a PVC, I don't care how that goes, but you would want to have both parts of that. And torsades, yep, that one was that one. How about this guy? Oh, actually, no, we're not gonna do that one because I don't know why I have two of those in there. Hold on. We didn't go over PACs because that's more than you guys need to know. How about this? Did yes. Check your pulse. Asystole. Yep. Absolutely. Absolutely. Oh my word, Ben, you better take that back right now. This is not an episode of Grey's Anatomy. No shock. How about this guy? I've got a sinus tach, which, yeah, but because of that rate, we're looking at SVT. Yep. That rate of 180 gives it away. All right, what about this little friend? Well, sinus, yeah, absolutely. And what rate would this be? All right, excellent. Look at this beautiful rhythm. Yeah, A flutter. It's those classic sawtooth. So if you think about A flutter being more organized than A fib, VTAC being more organized than VFib, it helps to kind of remember what's that going to look like at that isoelectric line. So here it's a lot more organized. That can really help when you're looking at it. So yep, A flutter. About this guy. Yep, third degree heart block. Dropping those QRSs. So look, we're marching out these beautiful P waves, man. They are just like, hey, I'm here. QRSs hanging out, doing its own thing, right? Absolutely no coordination between the two of them. Here's another one. Yep, we have another A flutter. Yeah, that regular sawtooth pattern there. 2 to 1? Yeah. I think this other one was 3 to 1. Yeah, that one would be 3 to 1. Yep. A flutter. What about this one? Yeah, A fib. So another thing to keep in mind is that A flutter is regularly irregular. So we have things are marching out. Our QRSs are marching out. We probably could even march out some of these P waves here. There's no rhyme or reason. We are not marching out. It is completely irregular. That isoelectric line, we got all sorts of just that fibrillation. 114. It shouldn't be my same sinus. I'll have to go back and look. I'll double check. It shouldn't be. I was pulling from a certain place, so I hope that it's not. All right. What about this one? Shay, do not be throwing bundle branch blocks in here. We're not doing bundle branch blocks. Yes. 3rd degree.
Why is it a 3rd degree when the PRI measures out before every QRS?
So they're, well,
Because they're still
hold on.
marching out, but the PRI is
They are. This was one that was thrown in there. No, you're right. They are marching out. We're missing a QRS. We're missing a QRS, but the P's are marching out. Yeah, 2nd degree again. Yeah, I would go a 2nd degree on this one. But again, there's not going to be these ones where you're sitting there going, there's no possible way. I don't know. It will be very clear based on information. I'm not going to try to trick you guys. See, like, look at how beautifully long that PR is. Look at that. Woo. What does that give us? Absolutely, 1st degree block. So it's very obvious how long that PRI is. It's not something you're like, oh, I'm not sure if that's a long. Yeah, very clear. What about this guy? Yeah, so this is actually considered normal sinus with PVCs. And because well, we don't know what's here, but we're looking at every 3rd beat. So it's trigeminy because it's every 3rd beat. You would not need to do that. You could just do normal sinus with PVCs. And fortunately, they're all coming from the same place because those PVCs all look about the same. So I don't like that they're in trigeminy, but it's better than if they're multifocal. Then the ventricles are really messed up and really angry. What about this guy? Yep, 2nd degree type 1. All right, and here we have one last one. Like your shorthand for Winky Bach. That's funny. What about this rhythm for our last one? SVT. Yep. All right. Questions, comments, concerns? Please come on Thursday if you have questions, if you want to pull strips and say, what is this? Bring them. Like I said, I'm going to be in the crash cart and med station, so we can throw in some strips in there as well. So please come if you have any questions ready for that. Otherwise, I will see you guys tomorrow for class. I'm excited. Anything else I can do for you? Oh, go ahead.
I have a question actually. Oh. Sorry. I had a question for that last one because I was a little confused, but I know there was only one bump between, but it made me think since it looked consistent, it didn't look bad, I thought it might be a, not a flutter, but yeah, I think that's what I thought, a flutter, but it's only one. So I didn't know if there would be a situation where there'd be one of those like waves between, and that'd be considered a flutter.
So when you're looking at a flutter, it is, you're going to, this is not, I can see where your confusion is because of the way these are looking, but this is not considered a sawtooth a sawtooth presentation. Plus, in order to have a flutter, there's usually a lot more atrial activity than ventricle activity. So you wouldn't have it be essentially 1-to-1 is what you're describing, or you have one beat, one atrial beat, which is our P wave, and a QRS for our ventricles. We really see that there's more atrial beats and then a QRS. So you would not. So this we're looking at that P wave. This is actually a T wave. Our P wave is buried someplace in here because it's so fast.
I think I just need to practice. I think I just need to practice some more because every time there's no P wave that's seen, it just messes with my head a little bit. Where I'm like, okay, I know this could be tacky something, but if I just see the QRS and the T, then I get confused with that. Sorry.
Well, and that's part of why we break down. Are we regular versus irregular? Number one, do we have a P wave? Can we see a P wave? Is there a P for every Q? Is there a QRS for every P wave? That's where we start to break these down, and that really helps you if you follow that with everyone. Even when we want to jump ahead and go, oh, that's totally, I don't know, AFib. We still want to follow those through because we're looking at the rate, we're looking at the rhythm. Are we regular versus irregular? And that helps us to stay on track with, okay, so you can go online. There's a couple different, I think Nurse Sarah has one where you can, it just will go through rhythm strips. Again, I am not going to be putting ones on there that are tricky. They're going to be very clear. They're very obvious. I don't want you guys to feel like you're not being set up to succeed. They're going to be very obvious